Hi there, I'm Scott Shemer. I'm an obstetrician and gynaecologist here at Epworth Freemasons Hospital. My private practice now focuses solely on obstetrics, where I enjoy caring for patients and their families with pregnancies that span the spectrum of normal to very high risk. Preterm birth is any birth that occurs prior to 37 weeks gestation. In Australia, this happens in about 8 to 9% of pregnancies. I think it's useful to split preterm births into those that are spontaneous, that is, a patient goes into labour prior to 37 weeks gestation, and those that are iatrogenic, that is, medically indicated or initiated because of a problem during the pregnancy that means that birth becomes the safest option. For example, severe preeclampsia or fetal growth restriction or any other concern about fetal or maternal well-being. There are a number of risk factors for spontaneous preterm birth, the most common being a history of a previous preterm birth. Others include surgery on your cervix, most commonly for an abnormal pap smear in the form of a comb biopsy or at least 2 LETs or LEAP or laser procedures. Having had multiple cervical dilatations, for example curettes for miscarriages or terminations of pregnancy, and we say at least 3 of these procedures increases your risk. Having any abnormality in the shape of your uterus, so some women have been told they've got a heart-shaped or double uterus or a uterus with a septum down the middle, or having had any obstetric cervical trauma, that is a tear to your cervix that occurs during childbirth, sometimes during a vaginal birth, at other times during a caesarean section, most commonly a Caesar that's been performed at full dilatation. There are a number of strategies that we can implement to reduce your risk of spontaneous preterm birth. The first of these is cervical surveillance. This involves seeing your obstetrician every fortnight throughout the second trimester to monitor the length of your cervix. The shorter the cervix, the less strong it is, and the more likely you are to go into spontaneous preterm birth. If we can identify that your cervix is shortening, then we can implement other strategies to help reduce your risk. The second of these is progesterone. Progesterone is used as a vaginal pessary in Australia once a night and to further reduce your risk of preterm birth. The evidence for it is very clear in women with a short cervix, slightly more controversial in women with a history of preterm birth but a normal length cervix, and each case really needs to be individualised with your obstetrician. The third of these is a cervical suture or stitch. These can be put in different situations. Sometimes they're put in electively at about 13 to 14 weeks in pregnancy for women at the highest risk of preterm labour. They can also be put in later in a pregnancy up until about 24 weeks gestation, where a short cervix or even an open cervix may be identified on ultrasound or clinically during the pregnancy. We now have the availability of the transabdominal cerclage reserved for the highest risk cohort of patients. These are inserted either laparoscopically or even robotically and are ideally put in prior to pregnancy. It's for this reason that I suggest all women with any of the aforementioned risk factors ideally see an obstetrician prior to pregnancy so that a care plan can be individualised and initiated as soon as necessary. A transvaginal cerclage is a stitch that's inserted in an operating theatre under anaesthetic, either a spinal anaesthetic or a general anaesthetic. There are different techniques that can be used. I favour a McDonald suture, which is literally a purse string suture around your cervix with a non-dissolvable suture. The stitch is then removed at approximately 37 weeks gestation for patients hoping to have a vaginal birth. For those having a caesarean section, it's simply removed after your Caesar whilst you're still under anaesthetic.